Good day, and thank you for joining. I'm Sherilyn Francis with the Georgia Health Information Technology Center. The future of health IT is here. Turn it on. We encourage you to connect with us at www.ga-hitec.org and via social media at Georgia HITEC. Georgia HITEC is the only federal and state-endorsed expert to assist providers in the achievement of meaningful use of EHR technology, and we are located at the Morehouse School of Medicine National Center for Primary Care. And now a few housekeeping measures. As participants, your microphones are muted and shall remain muted through the duration of the presentation. We ask that you check your internet connection for an optimal webinar experience. This icon can be found at the upper right corner of your top navigation bar. Additionally, we ask that you refer all tech issues to the tech support chat pod, and we ask that you refer all presenter questions to the presenter Q&A pod. There will be periodic stopping points for question and answer, and there will be time designated at the conclusion of the webinar for question and answer. I present to you today's webinar entitled
Thank you very much. So today what we're going to focus on are the changes in the meaningful use requirements from the original stage 1 and stage 2 to the modified stage 2. We'll talk about what was deleted and what's included. We'll discuss how a provider can meet the health information exchange requirement, which is our summary of care for referrals, requirement, and we'll review registry requirements and how you can meet those. I wanted to start out by just taking a quick look at the participation timeline. We still will discuss discuss 2015 throughout this presentation because we do have many Medicaid participants who are still testing. And will be through August. 31st. So if you were testing for 20, May 15th. With Medicaid. Then you'll attest to the modified stage 2. requirements that were provided in 2015. But you will only have to report for a 90 calendar day, and that is for all participants for meaningful use. For 2016, you will attest to the modified stage 2 requirements. If you're in the first year, then it would be a 90 calendar day attestation. All other meaningful use participants will have to report for a full calendar year. Now, I know many of you have had questions and have heard rumors that it has been recommended that we go to a 90-day reporting period for 2016. That is not something that has been passed by law, so it is not something that we can count on right now. If it happens, that's great, but what you need to do is plan on meeting the measures. If you're in a subsequent year past your first year, you need to plan on meeting these measures for 2016 for one full year. In 2017, if you're on the Medicaid side, then you are scheduled to go to start utilizing the MAPR payment system, which has a new component, not MAPR, MACRA payment system. It has a new component that takes the place of meaningful use, but is very, very similar to the stage 3 rules. Or you may, if you're Medicaid, then you would continue along your modified stage 2 rules, or you can begin to move to a full version of stage 3 I don't think, I know no one that I'm working with is planning on doing that unless they're in the Medicare program. So we're going to focus on stage two. But if you would like to, then it appears that you can go to stage three in 2017, but you would need a 2015 certified EHR. And we're not even going to touch 2018 today. So let's just look at the payment year for 2015 attestation deadlines. And again, please bear with us if you're on the Medicare side because the Medicaid folks are still working on this, many of them. If you were in the first year or the Adopt, Implement, Upgrade AIU year for Medicaid, meaningful use, then that attestation opportunity is closed for 2015. If you're in a subsequent year, in a year past your first AIU year for Medicaid meaningful use, then that attestation program was open in July of 2016, and the deadline for your 2015 payment year meaningful use attestations for Medicaid is the 31st of August. So that doesn't leave us a great deal of time. So hopefully everyone is working on that or asking for some help from the Georgia HITEC staff if you need it to complete that. We're not going to get into a lot of detail on the Medicaid attestation, but there have been some changes in what you need to upload when you attest, and we will briefly cover that. If you're Medicare meaningful use for 2015, then you were closed out in the spring. So Medicaid meaningful use 2015, you're done. There's nothing that you can do to attest at this point in time for 2015. Now let's look at the 2016 payment year attestation deadlines. If you're in your first year of Medicaid for Adopt, Implement, or Upgrade, then Medicaid is currently accepting 2016 payment year AIUs. If originally the deadline for this attestation for 2016 was earlier, and DCH has recently announced an update that the payment year 2016 deadline has been extended to 3/31/2017. Again, this is for your 2016 attestation. And so this is for all providers who are using data from 2016. And one of the reasons for the extension is because of all the delays initially with implementing the modified stage 2. This helps you in giving you time to upload your attestation documentation. It doesn't give you an extension on your attestation period, which must be closed out by December 31st. If your Medicaid meaningful use, in other words, you're past your AIU year, then your deadline for 26 meaningful use attestation per the recent update is 3/31/2017. If you are a Medicare meaningful use user, your deadline for 2016 meaningful use attestation is February 29th, 2017. All providers must attest to modified stage 2 objectives and measures. There is no stage 1 anymore. There is no stage 2 anymore. There is only modified stage 2 objectives. For 2015, for those of you in Medicaid still working to get that attestation completed, regardless of the scheduled stage that you were supposed to be in, you would report for a continuous 90-day period between January 1st, 2015 and December 31st, 2015. Very sorry. Apologize for that delay. Had some background noise landscaping outside, so do apologize for that. The next one is, so you do have an exemption if you do less than 100 orders. Folks, I have to tell you, this will be a hard one to exempt from if you have, even for a 90-day period, and almost impossible for a full year. The next one is computerized physician order entry for labs, and this is a greater than 30%. It is possible in some specialties for a 90-day period that you might exempt it. Some specialties might exempt it for a whole year, but not a great many. So you want to make sure that you're over 30%. CPOE imaging. Now, I do see a lot of providers um, qualify for this exemption because you have less than 100 orders for imaging during a 90-day period, not so much for a 100-day period. My recommendation, folks, is if you are doing your first year attestation, um, if you've met this measure, don't take an exemption. So if your measure, if you had 99 and you did 75, then you still meet this measure, and I would go ahead and put in your numerator and denominator rather than taking an exemption. The rule of thumb is if you're confident in your numbers and you're meeting the threshold, then don't take the exemption. Go ahead and complete that data in the system when you attest. E-prescribing greater than 50%, and again, exemption for less than 100 orders, pretty hard to hit for a full year. Health information exchange, utilizing your electronic summary of care document through direct secure messaging. There is an exemption for less than 100. Referrals, we see a lot of specialists actually meet this. I will have to tell you, we see more specialists meet this exemption because they're simply not doing it. And if you don't put the referral in as a summary of care, it often doesn't show up in your denominator. So I do want you to at least check and make sure this is working on your system. But if you have less than 100, you can exempt. Many, many people use this exemption for when they're in a 90-day reporting period. I know many from Medicare did for their 2015 attestations. Folks, this is not easy to exempt for a 365-day reporting period. So we would ask if you've still got time to make this work. And we're going to talk about this more later. Patient-specific education, greater than 10%. You need to meet that. MedRec, greater than 50%. And this is only tracking new patients, but technically, or in my opinion, you should be doing MedRec for all patients. But I do want to, if you have a zero in this denominator, then we would ask that you check and make sure this is tracking properly and that you know the workflow to make this work. Number 8 is patient portal, and this is greater than 50% of your patients have access to the portal. Now, I know some of you out there, all you have to do is put in an email address and it gives you credit for this. Other EHRs make the patient log in before it gives you credit. So you need to adjust how you handle this and how you communicate with your patients about participating if you are not meeting this measure, because we're over half the way through the year, and getting over 50% if you're at zero right now is going to be a tough haul. So don't wait on that. View, download, transmit. This just requires at least one patient has accessed or utilized view, download, and transmit. Just one patient, folks. This was an adjustment. We're very glad for it. It's a yes/no response, but you do have to have proof. Some of you, this measure shows up on your dashboard or your scorecard from your EHR, so you have access to this data. For some of you, it does not show up on your dashboard. So to prove this, you're going to be able to have to take a screenshot from your audit trail or your audit log for your patient portal or some other tool or resource that you can inquire with your EHR vendor about. You have to be able to prove that you did this. Again, if it's on your meaningful use report and you have at least a 1 in the numerator, you should be fine. If it's not on your meaningful use report, you have to prove that it occurred during your attestation period. Secure messaging. Again, I've already covered this a little, but at least one message needs to be sent to a patient from each provider. Now, some of you may wonder if if it really needs to be the provider. Some of you folks tell me that your mid-levels actually are the ones that are responding. And what I have to say to you about that is this. It must be reflected either in your audit log, on your meaningful use report for that provider, or through your portal log, that it shows that the provider made the response. Technically, someone else could have logged in and made that response, but on the report or on the screenshot of the audit log, it must show that the provider made the response. But folks, it's just one message. So you can do this. You can do this afternoon. Number 10, public health registries. You have to engage, you have to show that you have engaged with 2 registries, or you can engage with 1 and take 2 exclusions, or you can take 2 exclusions. You must be engaged or show due diligence, proof within the first 60 days of your attestation period. Now, this is the requirement. And what this means for 2015 is that you would have had to have done it probably by the 1st of December. If you didn't do that and you did it in the month of December or at some other time, I would recommend that you still utilize that information. There does seem to be some flexibility, but until we see some audits on those, we won't really know how that's going to be felt. The same is true for 2016. Technically, you should have had this done before the 1st of March, because that would have been the first 60 days of your attestation period for your 365-day reporting period. Now, we're talking about subsequent years, not first years. So you should have done this in January and February. If you did not, then we encourage you to go ahead and do it. And beg forgiveness, if you will. I do think there'll be some flexibility, but I cannot guarantee that flexibility at this time. But don't waste any more time if you haven't done it. Get it done. These are yes/no questions, but you will have to be able to prove that you've engaged, or we'll have to substantiate your exemption. And we have several screens to talk to you about that. So again, yes/no measures require additional documentation for audits and for Medicaid attestations. You must upload proof for all your yes/no answers. For threshold measures, for Medicaid, you would upload the meaningful use report. For audits, you would provide the meaningful use reports for threshold measures. Now, I see that we're creeping up. I would like to at least get through to our registries and then hold that off for another session so we can answer some of these questions, or attempt to answer some of these questions. Clinical quality measures. There's no real changes to clinical quality measures since we had the stage 2 rules. There are 9 clinical quality measures required across at least 3 of the 6 domains. We do strongly recommend you try to use quality measures that support your practice. We understand that sometimes you have to use ones that aren't applicable, but do first try to use ones that are. And we also understand that you may be limited by what's available in your EHR. But please do try to pick the ones that have a numerator and denominator, or at least have a denominator. It is acceptable to have zeros, but I sure wouldn't want to have a report that was all zeros. For payment year 2013 and for eligible professionals participating for the first time in payment year 2016, you must attest for any continuous 90-day period for the clinical quality measure data from the calendar year. You should use the same 90-day period for your clinical quality measures that you use for your meaningful use data. For payment year 2016, if you're beyond your first year of meaningful use, then you need to attest for 1 full calendar year for your clinical quality measures. So this is straight out of a presentation that was provided by the ONC, and it reflects on your health information exchange or your summary of care referrals. You'll notice that we've struck through it as a menu item. If this is your first year of testing, then you'll have some additional exclusions that you can take for 2015 if you were not planning to attest to this because it was a menu item. And folks, I know this part can get very tricky. Just read through all the requirements. And if you were not planning, if you're in your first year and you weren't planning to use this measure for a 2015 attestation, then you may exclude it. It is a stage 2 requirement for modified stage 2 for 2016 and 2017, even for folks that are in their first year. And obviously, for anyone that was scheduled to be in the second year, which is everybody but first year folks, it is required. The summary of care, which we call the SOC, is created with your certified EHR, and it has to be greater than 10% or electronically exchanged. And electronically exchanged does not count faxing. You need to use direct secure messaging or a peer-to-peer environment within your EHR to achieve this measure. There is an exclusion for less than 100 transfers of care or referrals during the EHR reporting period. I've seen many practices where this is not tracking. Again, if you're under 100, then that's great, but please make sure it's working. You do need to establish, to meet this requirement, a direct secure email address for exchange of summary of care referrals. Your EHR vendor may provide a direct secure email address or resource for this. It may be a free service. More likely it's something you'll have to pay for, but you do need this to get that 10%. Also, the Georgia Health Information Network, or GHIN, can provide you with a free secure email address and show you how to utilize this secure email address. It is very simple. It's like using email, and you may have to do some manual tracking through your email address, your direct secure email address, rather than your dashboard, and be able to provide those reports as proof. But it is a free resource available to you, and I've got a little more information on that. Please make sure that you understand how to generate the summary of care document from your certified EHR and that it is tracking. You will then need to obtain direct email addresses from providers to whom you refer. You can't, this is a situation where you may have your direct secure email address just like you might have a phone and your own phone number. But if you don't, if the person you're want to call doesn't have a phone, this will not work. So you need to make sure that you have the direct secure email address of who you want to send it to, and you need to test it with each of those practices or providers to make sure it's working. You will, once you open up your secure messaging, you'll attach the summary of care. In many of your EHRs, you can simply put that direct email address into that workflow screen and send or transmit, and it will send that and track it properly. Now that takes us to our public health and clinical data registry reporting. We do just have about 13 minutes left, so I have been asked to pause. We can come back to this in a later session, or we can perhaps record this and make it available to you so you can get the rest of this session. I would at this time like to go over some of the questions, and I wanted to see if it was possible for those to be read out to me or if I need to read them for myself.
Not at all. So we will read the questions for you. And again, we encourage you, if you have any questions, please submit those questions in the presenter Q&A pod. Although we may not have time to address them during this session, we will provide thorough answers in the immediate future. Question number 1, Ms. Henson. Not all providers have direct messaging addresses. Will there be any allowance given for this measure if we do not hit the 10%? And this is referencing HIE number 5.
Okay, so that's an excellent question, and it's probably one of the most popular questions. And the answer is, other than having less than 100 referrals during the attestation period, which is very hard to do for 365 days, there is no additional exclusion if you're in your second year of attestation. So this is something that you have to meet. What we recommend you do is you must contact those you refer to, ask them if they have a direct email address, and then tell them in order for you to continue to making referrals to them, you really need them to get the direct email address, and refer them to the GHIN site where they can get one for free. And they can also get training for free. So we strongly recommend you have a campaign within your practice to get at least your most popular providers that you refer to. Remember, this is just a greater than 10%, so it's easier to hit once you get going. And it is not required for all your providers. You just need to achieve it for 10%, for greater than 10%. So do a little campaign to your referrals. I know they often come around and drop off for your primary care providers. They often drop off little gifts during the year. Tell them the gift you need this year is for them to get a direct email address and for them to get it quickly. I will tell you the GHIN folks usually hop to it and can get you one of these within a couple of weeks, if not sooner, and they can help you make this happen. Do not hesitate. Good question.
Okay, next question. We need a little clarification regarding VDT. The question is, aren't there two measures that have been met for VDT?
Okay, so measure number 8 is patient access. The first requirement is that you have to provide access to over 50% of your patients. And many of your EHR systems are calling number 8 VDT. But the fact is that that 8A is you have to provide patient access. Some of your systems require that they don't just have access, that they have access. And that is specific to an EHR. Many don't require that. Some do require that. The actual B part is that at least one patient needs to have logged onto the portal and viewed their record or transmitted their record to another provider or downloaded their medical record. So I've seen a lot of practices just set a patient down and walk through them with us, have them go ahead and access it and check this one off, take a screenshot, done. So this is not hard to do, and I recommend if you've got a 0 in your numerator for this one, then you sit down with one of your patients that you have a good relationship with and walk them through this so you have at least one tracking. Now, if you needed this for 2015 and you can't take an exemption because it wasn't part of what you were planning to attest to, then that's going to be a problem for you Medicaid folks for 2015. But for 2016, everybody still has time to make this happen. So we strongly recommend that you do.
Okay, next question. And we would also like to note that some of you may have some more personal, practice-specific questions, and we can address those offline. So our next question is, do we need to implement 5 CD rules or 1 for modified stage 2 for the 2015 reporting period?
For the 2015 reporting period, if it was your first year, or you weren't, or it was your second year and you were planning to attest to stage 1 in 2015, then you will have an option to do 1 clinical decision support rule. Everybody else will need to do 5. And for 2016, then everybody needs to plan to do 5. And again, you would set up these clinical decision support rules, relate them to clinical quality measures, and make sure that you have proof, a screenshot that these alerts or clinical decision support rules are set up in your system. So again, if you were supposed to be in stage 1 for 2015, you can just do 1 clinical decision support rule. For 2015, everyone needs to have it as a goal to do 5. 2016. And for 2015, if you were supposed to be past your first year or your first 2 years, you would have to do 5. If you were supposed to be in stage 2 for 2015, you have to do 5. Gee, I hope I didn't make that more confusing.
Okay, our next question. In order to meet measure number 5, we need to be able to generate and transmit our CCD for 10% of our patients. Is that correct?
That is correct. Greater than 10%, so 10.02 or something to that effect. But you do need to be able to generate that CCD and transmit it either using a peer-to-peer environment or integrated network or direct secure messaging. An eFax does not count for this. It needs to be sent using direct secure messaging or some other resource that utilizes that technology.
Thank you. Again, many of you may have very specific or practice-specific questions, and we just placed the Georgia HITEC support number and email address in the tech support chat pod, and we will also place that in the presenter Q&A pod. And for these more specific questions where you may need further clarification, you can feel free to reach out to Georgia HITEC via email or simply by giving a phone call.
And I do see that we have some in the presenter Q&A pod. Are you able to see those?
Yes, that's where I'm pulling these questions from.
Okay.
Okay, so our next question, and there's a bit of a statement prior to the question. We are behind in times. We have only verified that we have the accurate percentage for Medicare patients and certified EHR programs for a few years ago. Would that still be considered stage 1? How about we just start there?
Well, it depends. That depends. I really can't tell from your description if you were participating in the Medicaid program or the Medicare program. But if you've ever attested before and you plan to attest in 2016, then you've pretty much lost access to those stage 1 requirements unless it's your first. Yeah, you will have some exclusions, but basically for 2016, everybody has to utilize modified stage 2 requirements with some exclusions if it's your first year. I do recommend whoever's asking that you might be somebody that wants to call into the REC and let us see if we can help you out a little bit with that one.
Okay, I believe those are the majority of the questions. Again, some of the questions are more personal and practice specific, and we ask that you contact Georgia HITEC for those specific questions. But we are still open for questions. Ms. Hansen, you can feel free to move forward.
Well, I see that we only have 3 minutes, and I've got about 20 minutes worth of slides, so I don't want to go into the rest of these slides. I don't want to get started and not be able to complete them. So it had been recommended that we go ahead and cut off rather than go ahead. But I did want to show everyone that, as you can see, we have a great many slides on this public health registry. Forgive me for flipping quickly, but I wanted to make sure that everybody knew that part of these slides will include some resource information. We have the Georgia HITEC contact phone, the helpline, the support line, our website where you can go in and join if you're not a member of Georgia HITEC, which we strongly recommend. CMS information, your Georgia Medicaid information, ONC, GHIN, which you may need for those direct messages to get that direct email address, and then Department of Public Health.
Okay, thank you. We have one more question, but again, we will save that question and provide a thorough answer in the very near future. Ms. Hansen, thank you so much for an informative and educational presentation, and we thank each of you for attending today's presentation. Additionally, part 2 of this presentation will be shared in September, and you will receive email notification. On behalf of Georgia-HITEC, we thank you for your attendance today, and we wish you a wonderful day. Again, the webinar presentation and recording will be made available on the Georgia-HITEC site, and that is www.ga-hitec.org, and you can also connect with us on social media via @GeorgiaHITEC. Thank you.